Tuberculosis remains a significant health concern in Nigeria. In 2023, the country diagnosed over 300,000 TB cases, marking a historic achievement in reducing the gap of undiagnosed cases. However, children continue to represent a vulnerable segment of the population, accounting for approximately 7% of notified TB cases. Tuberculosis in children will be the bane of our show today. I am Aisha, Salihu, and welcome to Healthy Living on Trust TV. Despite being preventable and curable, TB often goes undiagnosed in children due to a lack of awareness and prevalent misconceptions. On today's show, we are peeling back the layers of this silent epidemic, exploring the symptoms, dispelling myths, and shedding light on the prevalence of TB in Nigerian children. And now joining us to do justice to this, we have Dr. Ndidi Iloduba, who is a pediatric infectious disease physician at the Federal Medical Center, Jabi, here in Abuja. Thank you so much, Doctor, for joining us on the program at this moment.
Thank you.
I'd like to hear from you. Could you start by explaining what tuberculosis is and why children are particularly at risk?
Tuberculosis is an airborne infectious disease that is caused by a germ, a bacterium called Mycobacterium tuberculosis. It's an old disease that has affected humans for thousands of years, and it's preventable and curable, like you said, but we still have it affecting not just adults but children. Children are particularly at risk of having tuberculosis because of their low immunity. Their immune system is not as developed as the adults, and so children, especially those less than 5 years, are at risk of having infections, especially tuberculosis. And apart from the fact that they are at risk of having tuberculosis, which we usually call TB, it's also challenging getting to diagnose and treat children with tuberculosis. So I'm glad to be here to talk more about this.
Okay, before we go deep into TB in children, I'd like to hear from you. What would you say are the risk factors or symptoms that one should look out for, even for an adult, before we come to children?
Okay, so the risk factors are different from the symptoms. For the risk factors that predispose children to having tuberculosis include a low socio-economic status, poverty in essence. When there is poverty, it's associated with poor nutrition, it's associated with poor living conditions. And so when there are poor living conditions, poor housing conditions, inappropriate ventilation, overcrowding, these factors will predispose to the spread of TB, which is an airborne infection. So when you also have conditions that depress the immunity of a child, for instance, the presence of HIV or cancers or any other, like diabetes mellitus, any other infection or any other overwhelming condition in the system, can predispose to the development of TB in children. In addition to that, children that live in institutionalized settings, for instance, dormitories, barracks, can also be exposed to TB because of the especially if it's a setting with poor ventilation. Then in terms of the symptoms of TB, things that we'll see and will make us think this child may have TB, it depends on the part of the body affected. Tuberculosis primarily affects the lungs, but it can also affect other parts of the body. So when it affects the lungs, it's called pulmonary tuberculosis. When it affects other parts of the body, it's called extrapulmonary tuberculosis. When children have pulmonary tuberculosis involving the lungs, they present with cough. Cough in tuberculosis is chronic. Chronic cough is a cough that has lasted for 2 weeks or more. So if a child is coughing for 2 weeks or more, we should be concerned and screen for TB. Apart from cough, they can also present with weight loss. That is a very important symptom or sign in children with TB. Weight loss or failure to gain weight. You see the child is not gaining weight as expected or is losing weight, the clothes are not fitting anymore in spite of the fact that the child is eating well. So weight loss is a significant symptom. Other symptoms include fever, which is usually persistent. And then they could also have drenching night sweats. That's sweating excessively, at night with the beddings and pajamas soaked in sweat. That's drenching night sweats. They could have chest pain. For those that can express themselves, they could say they have chest pain. Some of them will cough out blood. That's what we call hemoptysis. It's more common in the older children and also in adults. So you can have that. You can have malaise. That's a feeling unwell. Those are some of the common symptoms that children with tuberculosis present with.
Doctor, you have highlighted quite a number of risk factors and also symptoms for children presenting with tuberculosis. I'd like to hear from you. How then can parents differentiate TB symptoms from other common childhood illnesses?
Thank you for that question. To differentiate TB from other causes of other respiratory tract infections, for the parents, it may not be so easy. But the pointer here is once you have a child coughing for a long time, coughing for 2 weeks or more, you should be concerned and bring the child to the hospital, the nearest hospital, for a screening. We have the diagnostic facilities stationed in different parts of the town, in Abuja, and also in different parts of the country. So once there is a cough lasting 2 weeks or more, we should be concerned. But for those living with HIV, any cough at all should raise a concern, and we should screen such a child for TB. If you have a child that is not gaining weight, is not as big as expected compared to others, the peers, so that should also raise a concern. Or a child that has been growing well and then starts losing weight. And then if there is also a history of a contact. When we say history of contact, it means someone coughing in the vicinity, in the home. It may be a grandma, it may be a neighbor, it may be a caregiver, anybody, any history of contact with anybody that has been coughing for long. Probably the child was sent for holiday at grandma's place and grandma was coughing, grandpa was coughing. Such things should also make the parents a little bit more, concerned, and they should present as soon as possible to the nearest health facility.
Okay, Dr. Ndidi. Now let us look at mode of transmission. I understand that tuberculosis is an infectious disease, and we know that children are most vulnerable. You did mention earlier that children from age 0 to 5 are more vulnerable, and also children who are already presenting or who are HIV positive. Now, I'd like to hear from you. What would you say are the mode of transmission for tuberculosis? Because we have seen cases where adults are the ones, given this particular disease to the younger people, children. So what's the mode of transmission, and how can we nip it in the bud and curb it so that we don't transfer it from one person to another?
Okay, thank you. The mode of transmission for tuberculosis is an airborne infection. So it's transmitted primarily through the air from one person, the affected person, to others. So it goes this way. The person that is affected, while coughing or sneezing or talking, singing, laughing, the person releases and expels the organism, the bacillus, into the air. And then people around can now inhale this organism. And when this organism is inhaled into the system, it can now cause an infection. A lot of people, what happens after inhaling the organism depends on the immune system. Some people get exposed and don't end up infected or having the disease, but some others will get infected and progress to develop the disease. Then you asked how we can control the spread, since the route is already known. Before I move to that, I also want to say that one other way of transmitting tuberculosis is through ingestion of milk from an infected cattle, an infected cow. That's the bovine TB. That's not a very common means of transmission, but it's also there. So we need to know that. So especially for the unpasteurized cow milk that has not been processed. So for reducing the risk, the means of transmitting TB in our environment, a lot can be done. First is there's what we call cough etiquette and respiratory hygiene.
Okay.
So while generally this is whether it's TB or not, people are encouraged to cough in a safe way. So while coughing, we should cough into a disposable handkerchief and discard after use into a bin that is closed. that should be standard everywhere. If we all practice that, we will see that even for other respiratory tract infections, we'll be able to minimize the spread as much as possible. So coughing should be done into a disposable handkerchief or towel, which will be trashed into a bin that is covered. After that, the person should have his hands washed or use an alcohol-based hand rub. If a handkerchief is not available, the next option is to cough into the elbow. So we do this into the elbow instead of coughing straight into the hands and infecting the hands, shaking others afterwards, touching surfaces afterwards will now get to increase the risk of transmitting infections. So this simple acts of observing ideal cough etiquette and respiratory hygiene will help to prevent the means of transmission. The identifying the sick people, those that have cough, and treating them early is a very important aspect of control, because if the source patient is treated, the others are less likely going to be infected. For children, TB in children, it's always a sentinel event in the community. If a child has TB, it's a pointer to the fact that there's an adult somewhere transmitting the infection. So we will always encourage contact tracing to find out the exact adult in the locality, in the community that transmitted infection to this child.
Okay, doctor, earlier you talked about how it is almost difficult to diagnose TB in children. I'd like for you to walk us around that, so that parents who may have children presenting with symptoms and signs or have risk factors for this particular disease know what to do and where to take their child to for diagnosis before they are confirmed to be TB or otherwise.
So diagnosing TB in children can be challenging. That is because tuberculosis in children can present with non-specific signs and symptoms that can mimic other illnesses. And so we usually will have a high index of suspicion in terms of the clinicians to be able to pick childhood TB. We also have lots of training going on for healthcare workers at different levels, and a lot of sensitization and awareness programs to help increase our diagnostic acumen. It's apart from the fact that TB mimics other diseases, TB also in children can be difficult to diagnose, because the respiratory samples for making the diagnosis are not easy to obtain. So a young child may not be able to cough and bring out sputum for testing, which the older children and adolescents and adults will usually readily provide. So providing samples for the testing is not so easy, but thanks to advances, now we can even use tools for children to make this diagnosis. So another contributing factor to the challenge in diagnosis is the fact that they have what we call paucibacillary disease. This means that they don't produce enough of the organisms for testing in the respiratory tract. So they have little bacilli that may not be picked by the available diagnostic facilities available. So those are the challenges that we face, but a lot of things are put into place. The clinical features of the children are considered, so the signs and symptoms are considered. Then there are other supportive investigations. For instance, chest x-rays can be done for pulmonary x-rays, and they may show features suggestive of tuberculosis. So there are a lot of things we put into place, blood tests, and there's a place for making a presumptive diagnosis. That's a clinical diagnosis where everything is tied into making that diagnosis, even in the absence of the definitive diagnostic facilities. So on the part of the parents, it's important that they don't just go to the roadside drugstores and pick drugs and go home. If a child is coughing and the cough is prolonged, the cough is 2 weeks or more, this child needs to be assessed in a hospital. Any hospital, even the primary healthcare centers have dot centers where these tests can be done. So parents are encouraged, if the child is not even coughing but it's losing weight. When we talked about the symptoms, I just remembered now that I didn't talk about all the symptoms. I just mentioned the symptoms of pulmonary TB, that's the TB occurring in the lungs. We can also have TB occurring in other parts of the body. For instance, it can present in the bones, and we can have like a TB of the spine, and the patient will have deformities along the spine, looking like a hunchback or a small protrusion. So that will occur with weight loss. So once a child is losing weight and it's abnormal, a parent should come for further evaluation. If a child is having an abdominal swelling, if the child is having fever, headache, convulsions, loss of consciousness, it may point to the fact that it might be TB affecting the nervous system. When there's an abdominal swelling, it may be an abdominal TB. It can affect even the kidneys. That's what we call renal TB. So when we have any abdominal presentation, and then we have persistent fever, there is weight loss, you may have cough if it's a pulmonary type affecting the lungs. So any of this should make a parent concerned, and the child should be brought for review, for screening and evaluation.
Indeed, I couldn't agree with you more. Parents have to be very observant of their children, just in case they notice any change, and then they take the right action. Now let us look at management and treatment techniques now. I'd like to hear from you. What would you say are the standard treatment protocols for TB in children, and how accessible are these treatments in Nigeria?
For treatment of tuberculosis in children, we use a combination of anti-TB medications. It's a combination of drugs that are given for a course of time. Usually we give for a minimum of 4 to 6 months. So for the pulmonary TB and some forms of extrapulmonary TB, we give for usually 4 to 6 months. For some other types of extrapulmonary TB, for instance, when it's involving the bones or the nervous system, it may be treated for up to a year. Okay. So it's a treatment that takes long, and is usually done under observed therapy, direct observed therapy. And in Nigeria, TB testing and TB treatment is free, absolutely free. It's being provided and organized under the platform of the National TB and Leprosy Control Program. So in all the DOT centers, TB medications are free of charge. So we usually will give a combination for the first 2 months, which we call the intensive phase, and after that we'll continue. And usually the patients are also monitored, and at the end of the treatment, they do well. TB is curable, and with the right treatment, right drugs, we have good results. And it's important to note at this point that adhering to the prescribed drug regimen and the way it's prescribed is very important, because these are drugs that are taken for a long time, usually once a day, so it's not stressful. So we are particular about getting to take the drugs as prescribed and not missing the drugs. Okay, so
I was actually going to come to the age range for this treatment procedure, because you have talked about one from 1 month to 6 months, another to a year. Depends on the severity of the condition. But I just wanted to know the age range. Is there a particular, you'd say for children who are this certain age, this is the kind of treatment they take, or is it something that is general?
It's not based on age, it's based on the type of tuberculosis. So if it's a pulmonary TB that's affecting the lungs, we usually will treat for 6 months or 4 to 6 months.
Okay.
So we give the first phase for 2 months, and then the second phase 4 months or 2 months, depends on whether it's a 4 to 6 month regimen. So for the one that lasts 1 year, we give the first one for 2 months as a combination of 4 drugs, and after that 2 drugs which are given for 10 months. So that's a total of 12 months. And then it also depends, another factor that determines the duration or type of treatment that is given is whether the TB is a sensitive TB, a drug sensitive TB, or a drug resistant TB. There are different types of drugs that we use. We have the first line drugs that we give for the drug-sensitive TB cases, and we also have the second-line drugs that we give to the drug-resistant cases. So it depends on the site, the type of TB, and it also depends on the whether it's a drug-sensitive TB or a drug-resistant one.
Okay, doctor, this now brings me to my next line of questions. Speaking about drug sensitivity and drug resistance, I'd like to hear from you. How effective is the BCG vaccine in preventing TB in children, and are there recommendations for booster doses?
Okay. For BCG immunization, it prevents the severe forms of tuberculosis.
Okay.
That's what it does. It doesn't prevent all forms of TB. It prevents the severe forms of TB. So it means that a child that has had BCG is protected from having severe, life-threatening forms of the disease. But that child may also have TB because it doesn't protect. It doesn't give 100% protection. Yes. Research works are ongoing to see how a better and more effective vaccine can be developed. In terms of the second question is about, sorry, can you remind me?
Okay, now let us come to the issue of debunking myths around tuberculosis. I'm sure in your line of profession you have come across people saying certain things that may not be true about, this infectious disease. I'd like for you to debunk some of these myths and put us on the right pedestal.
Well, the myths and misconceptions are so many.
Right.
So I'll just take them as I can remember. First of all, some people think that TB is a witchcraft attack. And so I'd like to put it that it's not. It's a bacterial infection. It's caused by a bacterium that is called Mycobacterium tuberculosis. So it's not a witchcraft attack. It's curable, and we shouldn't think that such children are under witchcraft spells. Another one I can remember is people think TB can be transmitted through shaking of hands. It's not transmitted through shaking of hands. The means of transmission is the airborne route. So it's when if a person infected gets to cough or sneeze, and the organism is expelled into the air, that someone next to the person, someone a close contact can get infected. So that's the means of transmission. Other myths include the fact that people think it's a genetic condition. TB is not genetic. It's not a hereditary condition. I think the misconception is because sometimes we have it happening in a household, everybody having TB in the household. That is because of the transmission route. So because it's an airborne infection, someone coming down with TB in the house can now spread it to others in the house. And that is why we are so particular about contact tracing. Once someone has TB, we need to trace the source and identify all other family members that may be infected so they can be appropriately managed. Another myth is people think that TB is not curable. It's like it's a death sentence. That's not true. TB is curable. TB is very much curable. If it's untreated, TB can cause much deaths. We have up to 50% mortality, 50% deaths when it's not treated. But if it's identified, and especially early, and the right combination therapy given, we usually will have very good cure rates, and the patients do well without even having long-term adverse events.
Okay, doctor, thank you so much for clearing the air on those, misconceptions and myths around tuberculous diseases. I'd like to hear from you just before we go. What initiatives are in place or should be implemented by communities and the government to reduce the incidence of childhood tuberculosis in Nigeria?
Thank you for that question. A lot needs to be in place. Recently, just early this month, we had the 2024 National TB Conference that was hosted here in Abuja.
Right.
And we had a lot of stakeholders, including the First Lady, in attendance. The aim was to bring about collaboration amongst all the stakeholders.
Of course.
So a lot of people need to be involved. Everybody needs to be involved. So we can see there's a lot of government commitment. The First Lady announced that she's a global and national TB champion. And we had like foreign investors, local partners, everybody, healthcare workers bringing in their knowledge and experience in TB to see how we can get on top of end TB. So there are a lot of programs that are already in place. The SDGs, the MTB strategy, everything is all working towards seeing that TB is ended. I think what we need to emphasize on is awareness,
right?
Like you are doing right now. When COVID came, there was a lot of awareness. Everybody got to know about COVID, how it was being transmitted, and the awareness was so much. But TB, up till now, we can see we still have a lot of misconceptions, stigmatization going on. If we can improve the aspect of awareness so that in our communities, patients are identified early and appropriate treatment is given, I'm sure we'll get to have a lot more improvements in the statistics. And then in terms of vaccination, our immunization coverage is not optimal yet. It's not every child that is receiving BCG at birth. So it still boils down to more awareness programs, advocacy to see that all children born are get their BCG vaccines. In addition to that, we also need to pay attention to contact tracing. When cases are detected and they are being treated, it's important we identify all contacts, including in their contacts at their workplaces, contacts at home. I met a family that I treated the child for TB, and it happened they couldn't identify the contact. Eventually, on further probing, it was found that it was someone that was giving a lift in their car, and while they were traveling, they coughed for long, and that was possibly the contact for that family. So you can see that it's difficult to even identify sometimes, but it's important, because if that person is identified and that source is controlled, it will go a whole long way to see that TB is controlled. So
most definitely. Thank you so much. There we have been speaking with Dr. Ndidi Iloduba, who is a pediatric infectious disease physician at the Federal Medical Center, Jabi in Abuja. Thank you so much for your time on the program at this moment.
Thank you. Thanks for having me.
And now, remember, tuberculosis in children is preventable and curable with early diagnosis and proper care. Let's stay informed and protect our little ones. And that concludes this week's episode of the program, Healthy Living on Trust Television. Do well to follow us across all of our social media platforms, and also, you can check subsequent episodes, previous episodes of this program for comments, contributions, and suggestions. I'm Aisha. Salihu. Before we go, we'll be leaving you with some facts about tuberculosis you probably didn't know about.